You're listening to the What's Happening podcast with Gary Watts.
Good afternoon. I'm here with Dr. John Buatti, Professor of Radiation Oncology, University of Iowa. Welcome, John.
Thank you.
How are you?
I'm great.
It's a beautiful day, isn't it?
It's gorgeous.
So I want to talk about cancer today, which I was trying to think how many people are affected by cancer, but just about everybody has somebody either they know in their family is affected by cancer. But rather than start with cancer, let's start with you, your family. I know you're originally from New York City, how you got out here. If you can, just give us a little bit on your lovely wife, Anne Marie, and your 4 boys.
Yeah. So, I'm originally from New York City. My dad was one of those old-fashioned general practitioners.
Uh-huh.
And, as a kid growing up, I realized that my dad had kind of made it out of the, slums of Brooklyn, New York. His whole family had worked in the garment district, and he did it by the whole family chipping in to send him to medical school. So for him, education was the way out of essentially the Brooklyn ghettos. And he certainly instilled in all 8 of my brothers and sisters the importance of education and doing it. And so ideally, I realized, he did pretty well. Maybe this isn't so bad. And after working a number of different manual labor jobs in high school and, through college, realized, medicine isn't so bad. So I fully expected to be in general practice like my dad. But then in 4th grade, I had an experience where probably the first little girl I had a crush on ended up getting diagnosed with osteosarcoma. And, I was...
Which is bone cancer.
Which is a bone cancer.
Right, okay.
And that bone cancer had spread to her lungs, and she was pretty sick, but she seemed to be getting along well. And then she ended up being the first person who I really knew who died. And I remember going to her wake as a student. I was probably in like freshman year of high school, and just like pledging this is wrong. And if I was going to go into medicine, I wanted to make it not wrong and fix it. And
Right.
I really, you could kind of, it's always sitting in the back of your mind, and you don't think about it a whole lot until you get to medical school. And when I got to medical school, I was just obsessed with learning everything about cancer and how to fix it and how to do it. And initially thought I'd do medical oncology, but then switched and ended up doing radiation oncology because I thought we could do some really interesting research and things in the field and contribute. And that's really what I've spent my life doing. And
So how many people would know that Dr. Buatti got his inspiration from a 4th grader?
yeah,
A lot of people don't know that, do they?
No. A lot of people don't, and people don't think about how much things like that growing up stick with you,
Yeah.
but it really does.
How'd you get to Georgetown? Tell us about Georgetown.
Yeah, so I got to Georgetown actually. Interestingly, my dad had gone to medical school there, and my older sister went to medical school there, and initially, didn't think I'd end up going to college there, but there was a lot of difficulty and competitiveness getting into med school. So my dad said, well, you could go to college down at Georgetown. So I went there and then did go to medical school there, and kept the family tradition, which wasn't too bad, and got a good Jesuit education and double majored in philosophic theology. And
Really?
yeah, and it was a great place to go to school. So
Good. And then you get a medical degree too at Georgetown,
Yep.
right? And then residency at Arizona.
I did 2 residencies. Actually, I did internal medicine at Georgetown and then did a second residency in radiation oncology at Arizona.
Oh, really? So you were there 4 years, 5 years?
At Arizona, 4 years.
Yeah.
Yeah.
Good. So then where'd you go after Arizona?
Then my initial faculty job was at the University of Florida, and was an assistant professor there for about 6.5 years prior to coming here to the University of Iowa, where I've remained for the last 25. And
25.
And
Since 99, right?
Yep. Fully planning to spend the rest of my life here.
So when you recruited to Iowa, tell us about that. You think, oh, what are you going to do in Iowa? What's in Iowa?
Yeah.
Just hogs and cattle, beans and corn, right?
Yeah. So, people actually laugh. Truth be told, I honestly did. When I was invited, I'd read articles from Iowa because the university was really good, and I knew they did a whole bunch of research, but I had no idea where it was, and I really did have to get the map out. And then I found out where it was, and I came out, and obviously I got hooked.
Yeah, it's easy to get hooked. So, well, let's get into. So you're married, obviously, Anne Marie, and you have 4 sons, right?
Absolutely.
Ages.
Ages are between 30 and 25.
25. So they're out of the house, right?
Yeah, they're all out of the house.
They're all gone. So I bet they kept you busy too over the years, huh?
Yeah, and,
So-
and definitely my wife's a saint because she took care of the boys.
Yeah. And your hobbies are tennis, anything else? You've been on Ragbri, right?
I've done Ragbri 15 times,
Really?
and I have a nice vegetable garden. I like to do gardening around, and I grow dahlias, and
Okay.
and I also like to cook.
You
know?
like to cook?
Yeah.
Italian food, right?
Absolutely.
I hope so.
Yeah.
Let's dive into cancer and let's talk about maybe in just, we talked about how many lives it impacts a year, and most everybody has known somebody that has it or suffered with it or was treated or whatever. What are the different kinds of cancers and what can you tell us about cancer? And basically, let's start with what is it?
Yeah.
Wild cells or something goes awry in your body.
Yeah. So cancer really is just the aberrant proliferation of cells. If you think about it, everybody has millions and millions of cells in your body, and it's normal for them to divide. I mean, if your
Right.
skin cells didn't divide, you wouldn't get new skin. You disintegrate. So it's supposed to divide, but it's supposed to do it in a controlled manner so that it goes through. And cancer is really an uncontrolled growth of those cells. Now, why does it happen? It probably happens, largely due to genetic things, but that's a complex mix. So let me drop back because you also asked what types of cancer.
Right.
Essentially, if you can name the cell, you can get a cancer of it. So there are cancers of virtually every part of your body. That the most common ones are, lung cancer, colon cancer, prostate cancer, breast cancer, and they're probably organs relatively that get exposed to things that are toxic and also have hormonal influences, so their growth is a little bit more than maybe other parts of the body. So cause is really, I always say this, and it's a little counterintuitive, but really, if you live, okay, you are making DNA breaks, and you're making what's called free radicals, which are essentially what metabolism does. When you eat food, you have to break it down chemically to make energy so that you can move around and do all the things you do. Well, that process of breaking that down and making energy creates these very reactive compounds, and that's useful when you make energy, but it also causes damage to DNA and other molecules around it. Well, your body is very good at repairing that. So the vast majority of the time that happens, you're fine. You clear it out, it's taken care of. Occasionally one gets loose, and when it does get loose, it can cause a cancer. It's usually not even one mutation. Usually you get one, and sometimes you need a second one. And a lot of cancers now may have 6, 7, or 8 different kinds of mutations within it that then create the cancer that you observe down the road. So it's really a consequence of living. And then on top of that, just add in the other things we do that can make it more damaged or kind of contribute more. So if you smoke, you're actually adding a toxic compound in there that's going to add more of those reactive energy type compounds. Or if you get radiation, if you got a lot of excess radiation from a nuclear bomb or something, that actually will also cause more of these damages that your body has to take care of. So really, in a way, that's also why it's a disease of older people generally. It's much more rare. It does happen in children, but it's less common, largely because of it. You have to build up those basically errors that in your molecular system.
Do cells die and then you rejuvenate cells?
Absolutely.
All the time. So
Yeah.
is that where they get mutated as they come into the new cells that are already?
Yep. So we all have these. Some people talk about stem cells,
Right.
and so there are stem cells that make all the blood in your bloodstream. There are stem cells that are rejuvenating your skin. There are stem cells in the colon, and when those cells are dividing, it's when they divide and they pick up those errors that they can turn into cancers.
Is that why they use stem cells like your shoulders hurt or rotator cuff? You can use stem cells and
Yeah. Well,
to help rebuild it. Is that?
Yep. So same principle. If you get new stem cells in, then it can rebuild normal structures too. People are trying to use stem cells to regenerate organs and everything else. There's a lot of research being done in that field.
That gets into cloning too, doesn't it?
Yeah.
Do you guys do anything at Iowa in cloning or Nothing at all.
No,
Don't
we're
even-
not. Yeah, yeah. I mean, we obviously grow cells and we go and do that but to do true cloning is a totally other.
So you got, so as far as cancer, it's what we eat. You try to stay away from smoking, of course. Alcohol too?
Alcohol definitely has toxic effects. And so particularly in oral cancers and things like that, you're going to be much more predisposed to.
It's like guys that chew. Once in a while, you can get tobacco. You get it in your
Yep, chewing's bad
face.
too. You're going to create a lot of carcinogens around your mouth, and you're going to be much more apt to get oral cancer. And then, since you swallow a certain amount of it, no matter how hard you try not to, you're going to have an increased rate of anything in the esophagus or other things going down. Same thing with alcohol.
Tell us about sugar and cancer. Is there any
Yeah.
connection between sugar and
Yeah.
cancer?
Yeah, so there are associations, and they're somewhat complex. If you look at sugars, right, so you can think about it two different ways. Cancers eat more sugar because they're actively metabolizing all the time. So holding back sugar can actually help them not grow as much. But the other thing sugars do, if you look at somebody who's basically chronically eating sugar and gets overweight and is out of shape, what you probably do is accumulate certain hormones that then are more apt to predispose you to cancer. So the relationship between obesity and cancer is complex. There's also complexity regarding the immune system. So the immune system is probably affected by sugars. We all have. It's very complicated science. If you think about it, we all have a microbiome, right? So we all have all these bacteria, literally, probably trillions of bacteria all over us. And those help form your immune system to fight not only against different bacteria, but your immune system also circulates, and if it sees a bad cell, it'll go and take it out. And it'll take out even a cancer cell you made, and you may never know, you had a cancer cell, it just got taken care of. Well, the diversity of that microbiome may be very important and may be affected by what you eat and how you eat and the rest of your environment. And right now, I don't think we know how to control that, but I'm sure sugars and what we eat help control that. And we've learned biodiversity is probably good to keep cancers down.
So as far as the food, we have a lot of preservatives, and I'm sure that's not good for you, right?
Yeah.
And you try to get everything natural, and that's why there's so many natural groceries and natural stores and when you go out to eat, because the preservatives would be a chemical that would maybe cause cancer or react to.
Right. And I think the thing that's hard is, a lot of people, cite, people have never shown this preservative caused anything bad. But it's very hard to prove that, and I always use this example. Just think of how many years people smoked before they associated smoking with cancer. And the reason is you need a very specific inciting agent, smoking, and then a specific population that doesn't use it, and then another population that does. Well, now try and do that with preservative A that's in, jelly. Okay, who's going to do a survey and find out how much jelly this population eats versus another, and how much exposure do you have versus another? So it's very hard to work out the mechanisms of a lot of these preservatives and exactly what they do.
As far as cigarettes goes, I don't know if you remember this, but when I was a kid, it seemed like everybody smoked.
Yep.
And in a car, into a crowded bar, everybody smoked. And you come out and you just smell like a cigarette. And then the worst one that got me was on a plane. Yep. And it wasn't just you'd start off the tarmac, you'd start up, and you hear those little clicks, and everybody had the ashtray going on there. And when they stopped doing that, thank God we stopped that.
Oh, absolutely. I remember the Long Island Railroad. It was horrible. It was just a smoke bomb.
So what we eat, our environment, talk about genetics. So what our chemical DNA and genetics in people. Is there something that triggers certain things? If you sit down with somebody and let's say you had a crystal ball and you could predict if somebody's going to have cancer, is there is you study your genetics, your family, your mother and father. Would that help? And then also, is there a blood test that you can do, and it'll say, well, you have a chance that you're probably more prone for this?
Yeah, absolutely. So there's increasing evidence, and there's more and more different kinds of specific genetic mutations that are associated with cancers. And I'll give the example, and this is a family example. Okay, we have something that's known as familial adenomatous polyposis, which predisposes you to cancer in my family. Nobody ever knew about it, except my grandmother in her 70s got cancer. Then my mother in her 70s got cancer. And then my sister in her 40s got the same kind of cancer. Well, they went and looked at all the genetic mutations, and they can't find the specific mutation, but the criteria meets it. And it's usually associated with a group of about 2 or 3 different mutations. Now, the great thing about knowing this about your genetics is that then you can get screened. So we can do more rigorous screening specifically for colon cancer, prevent it, and actually, or catch it early so that then it doesn't shorten your life. And there are more and more syndromes like that being discovered that there were ones specific to certain kinds of brain cancer. There are ones specific to different kinds of colon cancers. There are multiple different syndromes. There are ones associated with some lung cancers. There are ones associated with, like lots of different, liver cancers, different kinds of brain cancers, children's cancers. So depending on when you can catch it, it can do it. And even the common genetic tests, whether it's 23andMe and some others, can actually identify some of those common mutations in groups. But that list, I would say, in the next 20 to 30 years, I'm almost certain will increase.
Yeah, it's interesting to me on genetics that, a lot of people on colon cancer, I think after 50, they recommend a colonoscopy. And then every 5 years or 10 years in case they find a polyp. But just do it. For the listening public, it's not that big a deal.
Yep.
I think a lot of people have a lot of anxiety. I don't want to do it. But, if you do that and you're prone to it, it's very preventative then. And they can find it and take care of it in an early stage. And you want to catch it early, right?
Yeah, absolutely. I mean, I think that whether it's mammography for women with breast cancer and getting a PSA and an exam, all those things. I mean, catching things early today is really, really helpful because you can cure a lot of cancers, and the number of cancer survivors is really increasing, exponentially. We're allowed, we can keep people alive with cancer for much, much longer, and we can truly cure people and get them out of being in a cancer state.
Prostate cancers, I think after 40, they recommend just a simple blood test. Yep. And it just shows your PSA, which is not a big deal, and you don't even know. But check it. And I think guys need to know that they just need to have it checked. Yep. I understand that most guys that pass away, 80s or what the practicality is when you do pass, they have all of us have prostate cancer. Yep. It's just whether you pass with a heart attack or some other type of cancer, but you do have that in you. It just depends on whether or not it's activated or whatnot. So, I'm a prostate cancer survivor, and I had it surgery and had it removed. So. Rest is good. So, you find out, you keep up on your PSA, you do your blood tests, and you can prevent things.
Yeah, absolutely. And you can be a cancer survivor for 20, 30, 40 plus years. I
know several ladies that have breast cancer and they've got it, they found out early and they had things taken care of. And so let's talk about lots of types of cancer. And we got skin cancer. Talk about skin cancer. A lot of people don't realize when their kids are out running around the sun, you don't put anything on. I know I was guilty of that.
Yeah.
Actually, my hair used to be blonde, but that's a long time ago. Is it the ultraviolet light or what's going on with the cells?
So it really is the ultraviolet light. When you look at the sun, the sun has a component of ultraviolet light. It comes down, it hits all your skin that's exposed. And so sunscreen is really, really important, and it's really important to do young. And we don't think about it a lot. Right. People like to go out, and honestly, people used to do a lot of sunbathing. People go to go to tanning salons. I mean, these things are just plain bad for you.
Right.
It should be in the category of smoking, right? You really don't want to do it. So. You really don't want to get tan and get a lot of exposure to the sun, and you don't want to get bad burns. Later on, it predisposes you to cancers, particularly melanomas, which are very aggressive. There are squamous cell carcinomas, which is different kind, and then there's basal cells. So there's lots of different types of skin cancers, but the worst is melanoma.
So one of the symptoms of cancer, a lot of times people, I didn't know I had cancer. How would I know? Maybe a lot of people don't go to a doctor. Maybe they don't have an annual physical, which another thing is I'd suggest after 40, I'd have an annual physical. I know I was always trying to find life insurance and partnerships, and they said, well, you need a physical. So I think it's smart for anybody, whether you need the insurance or not, go get a physical. So what are some of the symptoms? I know I did something really silly when I was younger, wasn't very old. There was a friend of mine who had lost a lot of weight. And I go, hey, man, you look pretty good. You lost a lot of weight. And he goes, well, I have cancer. And I go, oh, that was real good, Gary,
Yeah.
But obviously weight loss, fatigue. What are some maybe some blood loss?
Yeah, so there's a lot of different symptoms, and so let's go through the common cancers. So, probably for lung, which is the most common, weight loss subtly over time, decreased appetite, just a general feeling of not feeling good, unenergetic. That's one cardinal sign. Second one, a cough, an unexplained cough that's not going away, not associated necessarily with a fever. A clear one, like if you cough up blood, see a doctor immediately.
Right.
Make sure to get that checked out. If you have pain from anything that's waking you up regularly at night, you should probably get that checked, because any kind of bone metastasis tends to get people to get pain at night. So if you find that it's getting you every single day, and those are the main things for lung cancer. If you look at breast cancer, you really should do self-exam. Masses.
For a lump.
Yep.
Find a lump.
Look for a lump. If there's a mass, you do it, and then get the regular mammography. Those are the two most important things for breast cancer. If you see changes, the other thing you can see changes on the skin around the breast or the nipple. If you see something like that, you should definitely get it checked, have a low threshold, show it to a doctor and get him to look at it. If you look at colon cancer, if your bowel habits are changing significantly, if you see blood in your stool, if you start seeing black or tarry colored stools, any kind of things like that, where you're changing your bowel habit unexpectedly, that's not typical for you, you should let people know. And that's another easy test. They have a Cologuard now that you can actually get a small sample and test it for blood. And again, same thing with both of them. Weight loss also goes along with both. And then prostate cancer, if you're having a lot of difficulty urinating, or you see blood in the urine, you see other things like that, those aren't necessarily common. But, if you're having more and more trouble with urination, go, see someone and get it checked out, and make sure you're getting your PSA checked as well. Right. Those symptoms are important, and we all tend to put them off, right? I mean, we all feel pretty good. I'd just go to the bathroom a little extra, and so don't shake stuff off, especially if it's there for a little bit.
What age of women do you recommend a mammogram?
I think today typically they're starting around the age of 45.
Okay.
If, however, I think it's important to recognize a lot of women have predisposing symptoms, because it's very common. It's something in the order of 1 in 10 women will end up having a breast cancer. So if there's any predisposing family history, then they'll start doing it earlier, sometimes 30 to 35. So
let's talk about different kinds of treatment. You got radiation, you have chemotherapy. When you see a patient, depending on the cancer, how do you know what type of treatments, or do you suggest, start with this, do this? Tell us about that treatment.
Yeah, so, as an oncologist, you really have to study every different kind of cancer. And, one of the things that I think is, I feel really, blessed about being at the university, is that we really get to subspecialize. So we have people that literally spend their careers studying breast cancer. I've spent most of my career studying, children's cancer and brain tumors. We have people that specialize just in prostate cancer. And so when you go to someone like that, there are different approaches to each of those cancers based on how they spread, and what they respond to. So some cancers respond better to chemotherapy. Some respond better to newer targeted agents that have, immunotherapy or these small molecules that go against very specific agents. Others respond much better to radiation. Some, surgery is enough. So, surgery is a really important part of most cancers, getting it, if you can completely remove something, that's a really good solution if you can do it. Sometimes if it has a positive margin, you can add radiation to that, or a positive margin, add radiation and a targeted agent. So there are a lot of different approaches depending on the very specifics of the different cancers. So my recommendation, see an expert, get somebody who really is, in that specific type of cancer that you're getting approached, and then make sure to listen to those recommendations and take them.
If you have chemotherapy, what exactly are in the drugs? Because it seems to me people that take chemo get sick. Yeah. They're weak. It seems like it destroys all the good cells.
Yeah, there are so many different kinds of chemotherapy. So it was interesting. There's a great book. It's called The Emperor of All Maladies, and it kind of goes through a nice history of cancer therapy and its evolution. And if you look back really at cancer therapy when it started, there were essentially no way to cure it. Some things maybe you could do surgery and that was it. And physicians at the Dana-Farber and a few other places started using essentially poisons with kids with leukemia, and they found they got the kids to live a little longer if they actually gave them poisons. And the reason it worked is because the rapidly dividing cells got killed off sooner. So the chemotherapy, the original chemotherapies were extremely toxic, extremely non-specific. This has improved dramatically. And the medicines to stop the side effects have also improved dramatically. I have some patients that have taken chemotherapy literally for years, and they're not all dragged out. Some are pills you can take, and they can be very, very effective. So, chemotherapy is a whole group of different kind of chemical agents, and their side effects are very specific to what those agents are and how they're being used and what dose intensity of them. So it's very hard to generalize about, chemotherapy, having X effect or Y effect, because they all are really, really different. So it's important to learn what they are and then get the effects. Now, with that said too, there's no question some of these regimens are tough and they are very toxic in the acute phase. But if you can get through a toxic acute phase and get cured, that's really, really good. And I have patients that have gotten through that and they're alive 20, 30 years later too. And it's the most effective therapy for some types of cancer.
Tell us about radiation and the progress in radiation, MRI and radiation beam, and you got all kinds of things going on.
Radiation similarly has undergone huge evolutions in terms of how to do it. So, when I trained, even, 30 years ago, we literally would get a plain X-ray. We'd know the bones that were around a certain structure, and we would have a wax crayon and we'd draw on a plain X-ray picture around the area we wanted to treat, and we aimed the beam at it and we'd make a block around it. Now, okay, it's completely evolved. We get very high resolution MRI and CT. It's in a computer. We can outline all the different normal structures, all the different, all areas that are involved in tumor. We use PET-CT imaging that uses molecular features of tumors specifically along with the MRI. And then when we deliver it, we can get a CT or an MRI every single day to target where it's going. So we can use very small margins. I mean, it used to be people using centimeters around the area where the tumor was because that's the only way you could reliably know you were treating it. Still worked then, but it works a whole lot better now with a whole lot less side effects. We've also learned that because we've been able to make these technological changes, we can give higher doses per treatment, and that makes the therapy more effective. And we can combine the therapy in new ways with things like the immunotherapy and with chemotherapies. Again, at the end of the day, you want the least side effects and the most cures.
So you can pinpoint it exactly where it's at and just get right at it, huh?
Yeah, I mean, for different brain things, we can treat things with an accuracy of 0.3 of a millimeter.
Wow.
In most parts of the body now, using MR and CT technologies, we can get down into the millimeter range in terms of accuracy of delivery of where we want it on a daily basis.
Is imaging now in 3D, or is it still?
No, it's definitely 3D, and we have full volumetric imaging. It basically, in a lot of ways. I mean, sometimes I tell patients when I'm doing their treatment planning, what we essentially do is when I get a detailed CT and MRI, it's kind of like a video game. I basically have a model of you in the computer of your inside, outsides, everything, and then with that model, I can outline the areas we want to treat and figure out how to aim hundreds of beams basically at the area that I want to treat and figure out how to avoid the normal structures. So a lot of physics and technical aspects to actually enable you to do that. But it's very, I think technology and computer science have made huge impacts in terms of how we do treatments.
And the laser actually burns it? Is that when it destroys the cell?
Yeah, but
it's not. It's radiation.
It's radiation. So it's photon radiation.
Okay.
And the way photons work is you really can't see them. The way I always like to describe it is that radiation works like light. Has all the same features of light, except you can't see it. So if I had a flashlight, as I go closer to it, it's brighter. As I go farther away, it fades out. Except it's a really strong light. So if I had the light here, it would go right through you. Now, when it hits you, it does get less bright as it goes through you, but it's a little at a time. Then what you do, just like a light, if I wanted to make a spot in the middle of the room the brightest, I could get lights from multiple different angles and just intersect them where that is. And I could make a marble in the middle of the room the brightest spot and everything else around it relatively dark. And that's kind of the trick of the way you use photon radiation.
How long ago did we come up with radiation therapy?
Oh, Marie Curie. And now I'm challenged on the date. I don't know exactly what the date is, but it was probably in the 1870s.
Oh, really?
Yeah. Yeah, because I mean, X-rays are used. She basically discovered, radium, put her hand in and saw that you could see, see her bones and everything. So it was a major advance. And then relatively shortly after that, somebody put a tumor in it and actually saw that it worked. So Marie Curie is really, Madame Curie is the, father of all, radiation application really to medicine.
So you have tumors, some are malignant, some are not. Then you get into lymphoma that gets into the bone marrow. Tell us about bone marrow and blood cancer and how do you treat blood cancer?
Yeah, so most lymphomas and bone cancer, it's in essentially the stem cells in the bone marrow. And most of them, that actually is one that has been traditionally one of the better responding therapies. Nowadays, they're still treated with a combination of chemotherapy and immune agents. So a lot of them use a regimen called CHOP, and they still can use that with a combination of rituximab. There are other immunotherapies, but the results have gotten better and better and better with time. Now, a fascinating advance, and something that really gave. Actually won the Nobel Prize for, right, is bone marrow transplantation. And if you think about that concept in terms of somebody taking a big risk, I mean, they basically took the concept that they could take, your bone marrow out.
Which is in my spine.
It's actually in most of your bones, but the majority of it for adults is in your pelvis and up in the lower part of the spine, and then there's a little bit more in the spine. But the rest of it still has some, but it's relatively little. But they could take some out. Okay, so they could take some out of you, and if let's say we were brothers, and they could take some out of you, they could give me a dose of chemotherapy or radiation to wipe out my entire bone marrow so that it would never come back. And then they could take yours, inject it into my arm, into the blood, and the cells would find my bone marrow, go back there and repopulate it. Okay. Now, I mean, whoever thought of trying that initially, that's a big risk. And actually, those therapies were very toxic when they first tried them. Now, bone marrow transplantation is a standard practice.
So you rebuild that bone marrow in you. You destroy
Rebuild
it
the bone marrow, and you can use somebody else's bone marrow to replace you. So I could actually have, I mean, you can have someone who has, I could be male and be XY, and if I had my sister give me their bone marrow, I would live and my bone marrow would be XY. Wouldn't really affect me, but on the other hand, the whole bone marrow has those genetic features of my sister, and they would remain there permanently.
It seems like when they figured out penicillin, I think that was in World War II or right in that time frame. Wasn't it bread mold or something simple? I mean, not simple, but just like here it is. Is there some simple thing in cancer research, or is it just so diverse and so many different kinds of cells and so many different kinds of cancers that it's so difficult to pin down? Because everybody wants a cancer cure, I think.
Oh, everybody wants it, but I think it's not going to be one thing. And if we've learned anything, it's that small steps make big differences in terms of making progress, from, X to Y. So, better radiation, better chemotherapy. A lot of the chemotherapies were actually derived from some of the antibiotics. When you look at, these agents, these small steps, bit by bit, get greater tumor control. So today, the outcomes are so much better than they used to be even 20, 30 years ago.
Okay. Tell us how COVID affected your clinic when you're dealing with COVID and mass and then patients coming in and out and your staff, your nurses and docs. How did you deal with that at the hospital?
So at the hospital, COVID's an interesting phenomenon to me. And I will tell you that it was very different in Iowa than it was in a lot of places around the country. I do know folks that were in, New York City and other places where literally because COVID was so bad, they actually had to have, the oncologist staffing ICUs and trying to do it. So frankly, the cancer patients with cancer, a lot of them in a way got neglected. They didn't get screened as much. People didn't want to go to the hospital to get checked for their mammography or other things or minor symptoms because they were afraid. So we probably had more cancer deaths due to that coming up. I can tell you here in Iowa, relatively, my first rule was, one, cancer's much more serious than risk of COVID for, anybody who's diagnosed with cancer. And so we went to work every single day and never shut down. And actually, we were busier during COVID because some of the operating rooms weren't open. I think some of the other clinics in Iowa didn't stay open. And I think a lot of patients then came to the university. So we were busier and committed to treat cancer the entire time. Our doctors, myself, came in every single day. Now, wearing masks, nobody likes it. I think it's hard, trying to talk to people through it, especially older people. It's also, you can't see people. It's just harder all the way around. But I think the university and Iowa did it, honestly, a really good job in terms of managing and trying to get patients who needed care in, prioritize taking care of the very sick COVID patients. And, fortunately, we didn't have so many that we were overrun at any time like they did at a lot of the East Coast and big cities. And we had enough intensive care unit beds in this state that we were able to manage it. So our experience was, I think better than most places. I'll also say, unbelievable amounts of respect for the physicians and the nurses and the respiratory therapists and all the people that really worked, on the front lines taking care of these folks. They were so good and so effective that frankly, as a radiation oncologist, I was able to continue to take care of the cancer patients, and I wasn't as directly engaged in their care. But those people did just an unbelievably yeoman's job, communicating with families. They couldn't have people come in if someone was dying of COVID and couldn't even see a family member, and they were trying to take care of these people. And that's
hard.
Yeah, really, really hard. So they get, they just can't get enough credit.
Let's talk a little bit about research. What are some, is there any breakthroughs in research and funding, and how much funding do you need, and how can people help? I know the Children's Hospital, we do the wave at first quarter in the football games to the Children's Hospital, and just all the neat things we do. And it just seems like on everybody's list is to give to cancer funds and research.
Yeah, I mean, we are making progress. So you can see that the investment in cancer research has made progress in terms of people's longevity and the outcomes. The thing is, the amount of funds, currently, if you look at the single biggest source of funds, it's still the National Cancer Institute. It's probably on the order of $6.5–7 billion a year. If you look at fundraising, like the American Cancer Society research-wise puts, I think, somewhere around $150 million in every single year. If you look at, funds at the university, at the Holden Comprehensive Cancer Center, and our department has its own, philanthropic fund. So we really do use all of those funds towards generating, new research, new ways to treat things. We have some very promising trials using high-dose intravenous vitamin C that, we've been, pursuing over a 10 to 20 year period of time that are starting to, pay some dividends, at least it seems in some sites. There's lots of research in new radioactive targeted agents and theranostics. There's research in, new small molecule drugs that can be used. And all of those tests not only require the basic science, but they require clinical trials to then test them in people. And you have to go through, you want to be safe. So you got to follow proper regulatory, procedures, and you have to get funding to try new things that aren't, approved by insurance. And so you really have to get funding to do that. So even though, it seems like there's a lot of money put into it, that money is paid off, and it's a slow march. There's no, when I was young, some people said, oh, you're not going to have to worry about being a radiation oncologist because there'll be the magic bullet. They're just going to, give people one thing and you're going to cure all the cancers. I don't think that's going to happen. I think there's going to be a slow, continuous improvement like we've seen. There'll be new drugs. There'll be, new spins of drugs. There'll be new combinations. And each one of them will make a very small step forward so that we, keep making progress on this. But the odds of finding a permanent cure for this, I think it's just not the nature of life.
How long does it take to get a drug through the FDA? Isn't it years?
Years, definitely
testing.
Years. Yeah.
So it isn't like that's why this COVID, shots we got for COVID, was it 6 months to a year they had that approved? Or?
Yeah. They had that, and they had a very specific, targeted. I mean, they actually knew what it was, and they could make a molecule that went against that. Cancer is not nearly as simple as that because everybody's cancer. I mean, you have one cancer, and it has a bunch of different mutations, and it makes it, but then it keeps mutating. So in fact, your one cancer may be 100 different kinds of cancers because the cancer cells keep mutating. So the one you started with may be a little bit different than the one you have a year later.
So I don't know if people realize this, but University of Iowa is obviously a teaching hospital, also a research hospital. How many people do you think work at the hospital that are in research? Any idea?
I don't know the number off the top of my head, but it's a lot. I mean, if you look at most of the positions, just in my department, I can tell you we probably have 50 to 100.
Just research scientists?
Yeah, just different kinds of scientists, people engaged in research. Some are involved in both clinical care and research, but if you look at people involved in research, I'm sure it's far in excess of 50. I would guess it's closer to 100.
And we're putting in, how much did you say? $6.5 billion?
$6.5 billion probably from the government. Wow. And then if you look at different institutions, like I was looking up a little bit of things, and I mean, fascinating. Like the single biggest philanthropic place is probably St. Jude's. And St. Jude's, I think it was like a year ago, actually, for the first time, broke $2 billion. That they were able to raise. And they're able to do unique things because of that. They can do like full genetic testing on every single cancer. So we don't have that capacity at the University of Iowa, but we could make much more rapid progress if we had that kind of, money to actually put towards it. So, philanthropic donations, I think, make a big difference in terms of making research. And the other thing to recognize is when you make philanthropic donations to the university, another really big factor is if you give a donation to the university, like when we get donations, then we put in grants to the federal government. And so that money you contributed turns into a lot more money because you can capitalize by your initial studies to get some of the $6.5 billion that the government's putting into it. So you're enabling future research to grow, and all of it moves towards trying to help cure and take care of cancer.
So it's something we probably, I've discussed in several shows, and obviously being a physician, how important when you think of cancer and just general conditioning is health, your diet, staying in shape, getting some exercise. I mean, describe that to us. I mean, because, most docs are in shape that I know. And just talk about I know we went through in COVID. I remember looking out my window in Oakdale. I saw numerous people on trails, riding their bikes, getting out and being active. And I think that woke us up as a population to say, you know what? I need to go do something, no matter what age you are, to try to stay in, at least be moving or stay in shape. Tell us a little bit, not just the mental side, but what that does for you from a physiological standpoint.
It definitely boosts all of you. I mean, exercise boosts your immune system.
Right.
It also boosts your ability to tolerate the free radicals that I talked about just with metabolism. So there's no question exercise has a positive impact in terms of cancer. There are many studies that have also shown that if you're a cancer patient and you exercise, your quality of life and your outcomes are better. So if you're not capable of it beforehand, it's kind of harder to get into. So I think everybody's staying in shape, eating healthy, taking care of yourself. One, I'll guarantee you'll have a better quality of life, and you will interact better with your friends and family, and you'll feel better, and you could probably prevent cancer with it too. So, taking care of yourself is, first part of being feeling good.
And it's something we all could do.
Yeah.
They can't take away that from you. If you want to work out, you can't take that away from you. Just go work out. Go for a walk.
Yeah.
It doesn't have to be go swim for 10 miles. It just maybe go for 5 laps or something.
Yeah. And I'll put in the guarantee you will feel better.
Right.
Yeah.
Right. Anything else you want to add about cancer today? Anything else that comes to mind that you'd like to share?
Yeah, no, I think for me as I've moved on, I think that cancer and taking care of it really has been a journey, and when I look back over my experience, things are so much better today than when I started 30 years ago, and that's what this is about. And when I started, it was way better than the people who trained me beforehand, and the people that are coming that I'm training now. Their careers, they're going to see things that are even better than what we can do now. So it's a slow journey. Everybody can contribute to it, both through their own self-care and through contributing. And I think that this is, doing good for humanity. And I always say one of my favorite sayings that I guess I'll end with. I usually end my holiday card with this too. Is always say a prayer, do good things. You can wake up every morning and say that, you'll feel good.
Well, I'm honored you came out today and joined our podcast. I appreciate all the work you do at the University of Iowa hospitals and clinics, and it's been a fantastic podcast. I appreciate it.
Yeah.
Thank you.
Least I could do.